Okay, let's dive deep into this stack of source material you've shared with us.
Sounds good.
Our mission today is to take your revision notes on vascular dementia, also known as multi-infarct dementia, and really unpack them.
Yeah, get to the core of it.
We're going to pull out the absolute most important high-yield nuggets of knowledge, helping you quickly grasp and retain this information.
Mm-hmm.
Think of this as turning those notes into a clear, memorable guide just for you.
It's definitely a critical topic to understand, whether you're revising for exams or just need a solid handle on the subject.
Right.
Vascular dementia, or VEND, sometimes called by its older name, multi-infarct dementia, MID, it's unfortunately very common.
So let's jump right in and define it. Based on your notes, what exactly is vascular dementia?
Okay. At its core, it's a type of dementia caused by damage to the brain from, well, impaired blood flow.
Impaired blood flow. Okay.
This often happens through multiple small strokes, which are called infarcts. Now, these aren't always the big, dramatic strokes people picture. They can be tiny, silent ones. Right.
But their cumulative effect over time leads to cognitive decline because that brain tissue gets damaged.
That makes sense.
Your notes also mention it can be caused by reduced blood supply more generally, or even small hemorrhages, and it's strongly associated with these infarcts and changes in the brain's white matter. That's referred to as subcortical leukoencephalopathy.
That cumulative effect makes so much sense. And right away, a key fact from the definition that just underscores its importance: it's estimated to be the second most common form of dementia.
Yeah, coming right after Alzheimer's disease.
Oh.
Absolutely. And the source material immediately connects this type of damage to underlying vascular risk factors, things like diabetes, atherosclerosis, and high blood pressure, or hypertension.
Okay.
That gives us a pretty clear picture, really, of what might be driving this.
Which naturally leads us to the causes. So what specifically is happening that leads to these infarcts and blood flow problems? What's the etiology, according to your notes? Well, the primary cause, as you noted, is damage resulting from multiple infarctions or blockages in the small blood vessels within the brain.
Right. The small vessels.
Exactly. These blockages are frequently the result of atherosclerosis. That's the hardening and narrowing of the arteries, or sometimes blood clots that disrupt flow to specific brain regions.
And your notes highlight different patterns this can take, listing the main subtypes.
Yes, they do. You have stroke-related VID, which can be due to multiple infarcts or sometimes even a single strategically placed infarct.
Okay.
Then there's subcortical VID, linked more specifically to damage in the deep white matter and basal ganglia from small vessel disease. And finally, mixed dementia, which is actually a pretty common scenario where you have features of both VID and Alzheimer's disease.
Oh, the overlap.
Yeah. Understanding these subtypes helps classify how the vascular damage is manifesting itself.
Okay, moving from the what and how to the who. This section on risk factors is incredibly important, isn't it?
Yeah.
Especially thinking about identification and maybe even prevention.
Definitely.
What does your source material list as the key things that increase someone's risk for MAD or VAD?
There's a pretty clear list of factors, and they really link back to overall vascular health. It might help to group them for recall.
Good idea.
First, there's older age, which, is a general risk for most dementias.
Right.
Then you've got the well-known cardiovascular culprits: high blood pressure, hypertension, diabetes, smoking, obesity, and high cholesterol levels. These all damage blood vessels over time.
The usual suspects, really.
Pretty much. Other significant medical risks mentioned include atrial fibrillation. That's an irregular heart rhythm that can cause blood clots to form in the heart, which can then travel to the brain.
Ah, okay.
Also, having a history of previous strokes or TIAs, those transient ischemic attacks, that's a major warning sign.
Makes sense.
And lastly, a family history of stroke or dementia can play a role too.
It's really striking, isn't it? Looking at that list, so many of those risk factors are things that can potentially be modified or medically managed.
Exactly. That's a key point.
This list isn't just about identifying risk. It strongly points towards potential preventative strategies, which makes it incredibly high-yield information for you.
Absolutely. It just underscores how interconnected our overall vascular health is with our brain's long-term cognitive function.
Now, for the how it works inside the brain, the pathophysiology, this is where it gets really interesting. How do those infarcts and blockages actually translate into problems with thinking, memory, and other cognitive functions?
Well, based on the source material, the key characteristic is the cumulative effect of these multiple brain infarctions.
Cumulative,
Think
right.
of it like small hits adding up over time. Each small stroke damages specific areas of brain tissue and, crucially, disrupts the complex neural networks.
Okay.
Those networks allow different parts of the brain to communicate and work together for cognitive tasks. So you damage the tissue and the connections.
And this leads to a vital point you mentioned, a real differentiator from, say, Alzheimer's.
Yes, exactly. The specific symptoms you see depend heavily on the location and the overall extent of the damage.
Location matters.
Hugely. If damage occurs in an area crucial for language, you'll see language problems. If it's in an area for executive function, like planning, that's what will be affected. It's very much about where the blood flow was disrupted.
That's a great point. Location, location, location.
Hmm.
It's not uniform damage, it's patchy, based on the vascular supply.
Precisely.
Okay, so someone is showing signs of cognitive decline. As you mentioned, it could be a few different things. How do we figure out if it's VID specifically, based on what your notes cover about differential diagnosis? What other conditions are on that list to consider?
Well, the main conditions you absolutely need to distinguish VID from are the other common forms of dementia: Alzheimer's disease, Lewy body dementia, and frontotemporal dementia.
Right, the big ones.
They can all present with cognitive changes, but have different underlying causes and sort of typical patterns.
And the diagnostic process described.
It's a comprehensive approach, a thorough medical history, formal cognitive assessments, physical and neurological exams, crucial neuroimaging like MRI or CT scans, and also laboratory tests.
That multi-pronged approach.
Exactly. It's this multifaceted investigation that allows clinicians to build the full picture and hopefully differentiate between these conditions.
And the lab tests are particularly important for a specific reason, right? To rule things out.
Exactly. Tests like a full blood count, B12 levels, thyroid function tests, electrolytes. They're done to exclude other potentially reversible causes of cognitive impairment.
Things you can treat.
Right. Things like vitamin deficiencies, thyroid problems, or metabolic imbalances can sometimes mimic dementia symptoms, and you absolutely don't want to miss something treatable.
So important. And the imaging, what's its key role?
Neuroimaging, typically a CT scan of the head or preferably an MRI scan of the brain, is essential to visually confirm the presence of the underlying vascular damage.
Seeing the evidence.
Yes. This is where they look for evidence of past infarcts, those areas of white matter, change the leukoencephalopathy, or evidence of past bleeds.
But the notes emphasize it's not just the scan.
No, definitely not. The diagnosis of VID isn't solely made just because you see some vascular changes on a scan. It requires putting that imaging evidence together with the clinical picture, the history, the exam findings, cognitive testing, reviewing medications that might affect cognition, and importantly, making sure those reversible causes have been ruled out.
Got it. Joining the dots.
Precisely. MRI is often preferred, especially if the specific subtype isn't clear, but a CT can be used if MRI isn't available or suitable.
And what might the MRI show specifically?
It might show clearly defined infarcts, small deep lesions, sometimes called cortical lacunae, and those widespread white matter changes we mentioned.
Okay. And one other point from the notes about assessment. Something else to rule out.
Ah, yes. Importantly, identify and treat depression. Depression can significantly affect cognition and memory, sometimes looking very much like dementia, so addressing it is a key part of the assessment process.
All right, critical point. Let's shift gears and look at the bigger picture, the numbers. What does the epidemiology tell us about how common MID or VAD is, particularly in the UK, according to your source?
Well, it reaffirms what we heard at the start. It's estimated to be the second most common cause of dementia, only after Alzheimer's.
Still number 2.
Still number 2. And, like most dementias, its incidence and prevalence are strongly linked to age.
Increases with age.
Yes, they increase significantly in older populations, especially once individuals are over 65 years old. This ties back directly to age being one of those key risk factors we discussed earlier.
Okay, now let's really get into what this looks like in a person.
Yeah.
What are the clinical features, the actual signs and symptoms noted in your source material?
Right. As we touched on earlier with the pathophysiology, the symptoms can be quite variable.
Because of the location.
Exactly, because they depend on where the brain damage from the infarcts has actually occurred.
So what are some common signs?
Common signs listed include memory problems, difficulties with communication or language, sometimes called dysphagia-impaired problem solving or executive function, mood changes, and sometimes even physical issues like problems with movement or gait.
Okay, so a range of things.
But here is perhaps the most characteristic clinical feature, and this is a crucial memory tip for you.
Okay, key takeaway.
Symptoms often show a stepwise progression.
Stepwise. Explain that.
So, rather than a smooth, gradual decline that might be more typical of Alzheimer's, the cognitive decline in VAD can happen in noticeable jumps or steps.
Oh, I see.
Often these steps happen following a new stroke or ischemic event. This stepwise pattern is a real red flag pointing towards a vascular cause.
Stepwise progression. Okay, that's a key phrase to remember.
Yeah.
Tied to those discrete damage events.
Exactly. Your notes also remind us of the general criteria needed to diagnose any dementia. Memory loss plus difficulties in at least 2 other cognitive areas, like orientation, attention, language, visuospatial skills, or executive functions like planning and problem solving.
Got it. And more specific presentations you might see in VAD itself.
Yes, things like unawareness of time and place, maybe trouble learning new information, difficulties managing daily activities, and behavioral or psychological symptoms like apathy or irritability.
And the notes say diagnosis is likely when?
When you have evidence of dementia alongside clear evidence of cerebrovascular disease, whether that's based on the person's history, findings on a physical exam, or, crucially, those imaging results we talked about.
Okay. And there are specific criteria mentioned for probable VAD. More memory points.
Yes, and these align with international standards, really helpful for recall. Key indicators for probable VAD include sudden onset of cognitive deficits.
Sudden onset.
That characteristic stepwise cognitive decline we just discussed.
Stepwise decline.
Early appearance of gait problems or urinary difficulty.
Early gait or bladder issues.
And cognitive symptoms starting within 3 months of a recognized stroke.
Right, the timing relative to a stroke. Okay, those are strong indicators.
Very strong. Those are key signs to look out for. The notes also list a wider range of potential symptoms you might see.
Such as?
Things like focal neurological signs, depending on the stroke location, attention deficits, seizures. Sometimes depression or anxiety can be the initial presentation, early falls, bladder problems not explained by urology, and features of something called pseudobulbar palsy, which affects facial movements and speech.
Wow, quite a list.
It is, and it adds a note to consider dementia with Lewy bodies if certain features like fluctuating cognition or visual hallucinations are prominent.
Highlighting the need for careful differential diagnosis again.
Exactly.
So if you're seeing these kinds of features and suspect VAD, what investigations are necessary according to your notes to confirm the diagnosis and ensure nothing else is going on?
Well, it's that comprehensive assessment we touched on again, the detailed medical history, cognitive evaluations, which might range from brief screening tests to more formal neuropsychological assessments, a thorough neurological exam, neuroimaging, CT or MRI, and those essential laboratory tests.
And we know why the labs are important.
Yes, primarily to rule out those other potentially treatable causes of cognitive impairment. Such a critical step before landing on a dementia diagnosis.
Absolutely. And imaging confirms the vascular damage.
Precisely. A CT head or MRI brain scan is used to visualize the infarcts, the leukoencephalopathy, those white matter changes, or any evidence of past hemorrhages.
But again, the notes are clear, not based on imaging alone.
Correct. The diagnosis requires putting the whole picture together. The clinical history, exam findings, cognitive screening results, a review of all medications, and confirming that other reversible causes have been excluded.
MRI often preferred.
Generally, yes, for better detail and distinguishing subtypes, but CT is a valid alternative if MRI isn't available or contraindicated. The findings on MRI often include those areas of infarction, small, deep lesions called lacunae, and the characteristic white matter changes.
And just to reiterate the point about depression.
Yes, the notes remind us again about identifying and treating depression, as it can significantly complicate or even mimic the picture of dementia.
Okay, we've covered diagnosis quite thoroughly. What about management? Once someone is diagnosed with MID or VAD, what does your source material suggest can be done to help?
Right, management. The overall goal is really twofold. First, to aggressively address the underlying vascular risk factors to prevent further brain damage.
Stop it getting worse.
Exactly. And second, to provide supportive care to manage the existing symptoms and improve the person's quality of life, and importantly, their caregiver's quality of life too.
Makes sense. So preventing further damage is a major focus.
Huge focus. This involves optimizing the control of blood pressure, managing diabetes and cholesterol levels effectively, and promoting healthy lifestyle choices. Like quitting smoking, maintaining a healthy diet, getting regular exercise if possible, and managing weight. This really is about stopping the progression by targeting the root vascular cause.
And rehabilitation therapies.
Yes. Things like physical therapy, occupational therapy, and speech therapy are also mentioned for their potential to help individuals maximize their function despite the existing damage.
Okay, what about prescribing management, medications?
The goal here is explicitly stated as preventing further atherosclerotic disease. So the main medications listed are those aimed at reducing cardiovascular risks.
Like statins and blood pressure meds.
Exactly. Antiplatelet agents like aspirin or clopidogrel to prevent clots, antihypertensive medications such as ramipril to control blood pressure, and statin therapy to manage cholesterol.
And for diabetes?
Optimizing glycemic control is essential. And an important point, if there's evidence of mixed dementia, so overlap with Alzheimer's pathology, then medications typically used for Alzheimer's might be considered.
Which ones are those?
Things like cholinesterase inhibitors, donepezil as an example, or NMDA antagonists like memantine.
Okay, so a lot of the medical management is really focused on preventing more strokes or damage, which fits with that stepwise progression idea.
Precisely.
What about non-prescribing management and support, things beyond medication?
Yeah, the notes suggest that specialized non-pharmacological interventions can be used to help improve cognitive symptoms. Examples given include cognitive stimulation programs.
Keeping the brain active.
Yes, activities designed to do just that. Also, reminiscence therapy, using life history and familiar items to trigger memories, and using familiar objects in the environment to aid orientation. Managing significant blockages in the carotid arteries in the neck, if present, is also mentioned, sometimes requiring surgery, an arterectomy or angioplasty, and stenting to improve blood flow to the brain.
Right, tackling the source of potential clots.
Yes. General symptomatic treatment is similar to managing other types of dementia, focusing on providing comfort, addressing specific issues as they arise, and providing crucial support for caregivers.
And always addressing risk factors.
Absolutely. Detecting and addressing those vascular risk factors is highlighted again as the primary way to potentially slow the progression. The source also refers to related articles and national guidelines, like NICE standards, for more detailed guidance.
Your notes list quite a few specific non-pharmacological interventions that can be tailored.
They do. Things like multisensory stimulation, using music and art therapy, encouraging dancing, massage, aromatherapy, structured exercise programs, and even animal-assisted therapy.
Lots of options to explore based on the individual.
Exactly. Aimed at improving well-being and function.
And what about managing challenging behaviors, which can sometimes occur in dementia? That must be tough.
It can be very challenging. The source strongly emphasizes the importance of an early, thorough assessment of any challenging behavior.
Before jumping to medication.
Absolutely. Before resorting to medication, you need to investigate potential underlying causes like physical health issues, pain, infection, psychosocial factors, medication side effects. Consider their personal history, their environment, and try to understand the behavior itself, what triggers it, what seems to maintain it.
Really digging deep.
Yes. The key is to identify and address those factors that might be making aggression or agitation worse. Staff training and managing these situations safely and effectively is also highlighted as important.
Okay. And if medication is considered for behavioral symptoms?
The notes mention considering anticholinesterase inhibitors or memantine if there's a suspected overlap with Alzheimer's pathology, as we discussed.
But there's a warning.
Yes, a strong caution mentioned regarding the use of antipsychotic medications for non-cognitive symptoms.
Why?
Due to their significant risks and side effects in this vulnerable population, particularly the increased risk of stroke.
Okay.
For severe or distressing symptoms that don't respond to other approaches, the notes advise carefully weighing the potential benefits against the risks and the possible negative impact on cognition.
A careful balance.
Very careful. Urgent options listed for acute agitation include medications like lorazepam, haloperidol, or olanzapine, but these should be used with extreme caution and typically for short periods.
That caution about antipsychotics is a really important takeaway for you listening. And finally, prevention is discussed.
Yes, prevention is covered, primarily focusing on modifying those vascular risk factors throughout life, especially in midlife, to prevent strokes and thereby reduce the risk of AD.
Makes sense.
Your notes add a slightly nuanced point about the evidence, though. While managing high blood pressure is generally good for vascular health,
Yes.
the evidence specifically linking hypertension treatment to a reduction in dementia risk isn't as conclusive for older individuals. However, it is clear that lowering high blood pressure after someone has already had a stroke can reduce their risk of developing post-stroke dementia.
Interesting nuance there. Okay, we've covered diagnosis and management extensively. What about the future outlook? What does the prognosis section tell us about what someone with MID or VD might expect?
Well, the prognosis is influenced by several factors. Things like the location and extent of the original brain damage from the infarcts, how well the underlying vascular risk factors are controlled moving forward, and the individual's overall health status.
So it varies.
It does. Your notes state that the condition typically progresses gradually over time. However, we have to remember that characteristics stepwise nature,
Right, the jumps.
which means that while the overall trend is decline, it might happen in noticeable drops rather than a smooth slope.
And compared to other dementias.
The notes indicate that VD generally has a worse prognosis compared to some other forms like Alzheimer's, partly due to the ongoing risk of further strokes.
And life expectancy.
It varies quite a bit depending on the individual and their overall health, comorbidities, and stroke recurrence, but individuals are noted as surviving several years after diagnosis.
Okay. And finally, what potential complications are listed that can arise with MD? What else might occur as the condition progresses?
The source lists several potential complications. Directly related to the cause, there's significantly increased risk of recurrent strokes.
That's a critical memory point for you. The underlying problem can happen again.
Exactly. Other complications include further cognitive decline and worsening functional abilities, making it increasingly difficult to manage daily activities.
Okay.
Individuals can become more vulnerable to infections, such as pneumonia, often related to immobility or swallowing issues. They may experience increased difficulties with communication and emotional well-being.
Behavioral issues, too.
Yes, behavioral issues can also arise or worsen, including things like wandering, developing delusions or hallucinations, or experiencing poor judgment. Depression is also listed as a common complication.
And physical complications.
These can include an increased risk of falls and problems with gait, aspiration pneumonia, inhaling food or fluid due to swallowing difficulties and pressure sores if mobility becomes significantly impaired.
And one last crucial one mentioned.
Yes, importantly, your notes highlight caregiver stress as a significant potential complication, recognizing the immense burden and impact on those providing care.
That list of complications really highlights the wide-ranging impact of this condition, doesn't it? It underscores the need for comprehensive, holistic care that supports both the individual and their caregivers.
Absolutely. What's particularly fascinating here, I think, is how inextricably linked our vascular health is to our brain health and cognitive function. This deep dive, pulling from your sources, really highlights not just a specific type of dementia, but the profound consequences of our cardiovascular well-being throughout life.
So what does this all mean for you? This information, taken directly from your notes, provides a comprehensive, high-yield overview of vascular dementia. It really reinforces the importance of understanding that underlying vascular cause, recognizing that stepwise progression we talked about, and tackling those modifiable risk factors to try and influence the course of the disease and support individuals living with it.
And this raises an important question for you to consider, perhaps. Given the significant number of modifiable vascular risk factors we've discussed, how much of a potential impact could widespread, effective public health measures focused on cardiovascular prevention actually have on the overall global burden of dementia? Something to think about.
That's a powerful thought. We hope this deep dive into your revision notes on vascular dementia, multi-infarct dementia, has been a valuable shortcut for you, helping you solidify the most important information.
Understanding these key areas, from defining the condition and its causes through diagnosis and clinical features to management, prognosis, and complications, it's essential, whether you're actively revising or simply building your knowledge base.
And if you are preparing for exams like the MSRA, getting these details locked down is absolutely key. For further resources and support tailored to help you succeed, you might want to check out PassTheMSRA.com and FreeMSRA.com.
Yeah, they offer additional material and practice questions to help strengthen your understanding of this and many other topics.
That's it for this deep dive. Keep learning.